Despite development of novel targeted agents, there's still room for chemotherapy, meaning that certain high-risk early breast cancer patients, they are really going to need chemotherapy, and there's been a lot of data historically suggesting that giving chemotherapy in a more compact schedule, in a dose-dense schedule, for example, giving every 3-week dose to every 2 weeks or weekly, that improves disease-free survival. So the rationale of the study was that can an alternative dose of anthracycline, which was doxorubicin in our study, which I will refer to as A, or cyclophosphamide, which I'll refer to as C, if that's given weekly versus the traditional every 2 weeks, if that would be better. So in this study, we did that in a design which allowed for randomization of patients to weekly AC versus every 2 weeks, and then the follow-up of that was patients were also then randomized by the taxane that they received. So that was given either as taxane every 2 weeks for 6 weeks or weekly for 12 weeks. So with the combination I just described, that actually allowed us to have 4 different treatment arms with the AC randomization and the Taxol randomization. At the time of first interim analysis, it was noted that the weekly AC arm, which was the arm that was being studied, was unlikely to be superior to the standard every 2-week arm. So the enrollment was paused at the time and the accrual was suspended. The trial then reopened with all the patients getting randomized to AC every 2 weeks, and at that point they were only randomized by the paclitaxel factor, meaning everybody got AC for 2 weeks, but then patients got paclitaxel either weekly or every 2 weeks. And another complicating bit in the design is that when the trial reopened and when patients only received AC, that AC was given every 2 weeks for 4 cycles. And in the first portion, in the arms that got AC every 2 weeks, that was actually given for 6 cycles. So we ended up with actually 6 arms total in the final study. In terms of patient demographics, they were largely very similar across the patients that were enrolled on the original protocol versus the revised protocol. There were some subtle differences that we called out in our presentation. In terms of the new arms, which was the additional 578 patients that we presented at SABCS, those characteristics were also really well balanced. In terms of the results, in terms of efficacy data, we demonstrated that there was no statistically significant difference in terms of disease-free survival or overall survival in any of the 4 treatment arms in the original protocol or in any of the 2 treatment arms in the revised protocol. So the conclusion is that the schedule did not improve efficacy. It actually did not matter what schedule patients took. In terms of toxicity, we did identify some signals. So for example, there was more myelosuppression in arms where AC was given every 2 weeks for either 6 cycles or AC was given weekly for 15 weeks, as opposed to AC that was given every 2 weeks for 4 cycles, which I described in the revised arm.